Usually, when we think about aesthetic medicine, there's this underlying assumption of a static canvas.
Right, like a predictable workspace.
Exactly. I mean, if someone wants more volume in their cheeks, a practitioner assesses the space, injects a dermal filler, and it acts, a bit like sculpting with clay.
Yeah, the underlying skeletal structure is rigid.
Right. The fat pads are mapped out, and the tissue generally just accepts the new shape.
It's a very architectural approach, really. You're adding structural volume to get a highly predictable, localized contour based on, well, a very well-mapped facial anatomy.
But step into the world of intimate aesthetic medicine, and that static canvas just vanishes entirely.
Oh, completely.
Oh,
It's a
yeah.
totally different ballgame.
You are suddenly trying to sculpt a highly dynamic, incredibly vascular, pulsing ecosystem. So, welcome to the deep dive. Today, we are looking at a fascinating and honestly highly debated intersection of aesthetic medicine and female sexual wellness.
We're talking about the G-shot.
Yeah, the G-shot or G-spot amplification, it's a procedure generating a massive amount of buzz online right now, promising enhanced sensitivity. But getting it right requires a level of microscopic anatomical precision that is just hard to overstate.
It really is. And to unpack this for you, the listener, we need to lay out exactly what we're looking at today, because we have a pretty dense stack of sources on the table.
Yeah, we do.
We've pulled official committee opinions from the American College of Obstetricians and Gynecologists, or ACOG, and the FDA.
Right.
And we've also got forensic case studies, including a very sobering autopsy report out of Korea. And we are cross-referencing all of those with highly technical clinical playbooks.
The actual step-by-step guides written for the practitioners who perform this procedure.
Exactly.
And the landscape we are looking at is incredibly fractured. I mean, the medical community is deeply divided here.
Deeply.
ACOG's official committee opinion bluntly states that these cosmetic vaginal procedures just lack high-quality, peer-reviewed data supporting their effectiveness.
Right. They're very clear about that.
Yeah, and they specifically highlight serious potential risks like scarring, tissue necrosis, altered sensation, and severe infection. And the FDA echoes that.
Yeah, they aggressively warn against the use of energy-based devices and injectables for vaginal rejuvenation outside of specific clinical diagnoses.
So the overarching stance of major medical bodies is that intervening in sexual appearance or function for purely cosmetic reasons, well, it simply isn't medically indicated.
No, the safety profiles just haven't been established in the kind of large-scale randomized controlled trials they require.
Which means we need to set a clear parameter for you before we go any further into this. We are not here to endorse, recommend, or judge this procedure.
Absolutely not. We aren't taking a side in the ethical or medical debate.
Right. Our mission for this deep dive is strictly analytical. Since the demand is skyrocketing and practitioners are performing this off-label procedure globally, how exactly are they attempting to do it safely?
That's the real question.
Yeah. Our specific focus today is mitigating disaster. How do these clinicians navigate this incredibly delicate tissue to avoid causing hyperdensity, firm nodules, or catastrophic systemic embolisms?
It requires a profound look at how human biology interacts with foreign materials in really high-stakes environments.
Yeah, and understanding the exact mechanics of these clinical safeguards kind of strips away the marketing buzz.
Yeah.
It shows us the raw underlying physiology.
Exactly. So let's start with the blueprint.
Okay, so
If a clinician is going to avoid creating a botched, hyperdense nodule, they first have to understand the specific tissue they are working with.
right.
When we talk about the G-spot or the Grafenberg spot, we aren't talking about a distinct encapsulated organ, are we?
No, not at all. It is not a standalone anatomical structure. It's more of a highly sensitive, neurologically dense neurovascular zone.
Located on the anterior vaginal wall.
Right. It sits roughly 3 to 4 centimeters deep into the vaginal canal, basically abutting the urethrovaginal space.
So we're talking about a concentrated matrix of nerve endings, glandular tissue, and an exceptionally rich blood supply.
And the clinical playbooks we're looking at indicate the procedure involves injecting a biocompatible filler directly into this zone.
Right. They are primarily using cross-linked hyaluronic acid.
Yeah, HA, they use it to create a temporary cushion about the size of a quarter. But I have to push back here for a second.
Okay, go ahead.
HA is the exact same glycosaminoglycan used in standard lip and cheek fillers. I mean, it's the same stuff.
It is.
So if a clinician uses the exact same syringe they just used on someone's jawline Does the vaginal tissue react differently?
Well, the fundamental physics of the HA molecule remain the same. It is intensely hydrophilic.
Meaning it binds to water molecules to create volume.
Exactly. However, the environment dictates the outcome. In facial aesthetics, a clinician is often injecting deep onto the periosteum, the bone, or into specific contained fat pads.
Right.
The anterior vaginal wall is fundamentally different. I mean, one of the medical texts we are reviewing literally describes it as a vascular sponge.
Wow. A vascular sponge. So the margin for error isn't just small, it's practically non-existent.
It really is. The clinical target is strictly the submucosal layer.
Okay, the submucosa.
Right. If a practitioner misjudges the depth and goes too deep into the surrounding adipose tissue, the filler just disperses uselessly.
It gets lost.
Yeah, the sensory nerves are bypassed entirely. But conversely, if they inject too superficially, placing the HA just under the mucosal epithelium, the filler lacks the structural space to integrate.
Oh, I see.
It expands, hits a biological wall, and creates a focal, hyperdense nodule, basically a hard, visible lump.
Which drags us right into the complication. Because the clinical guides spend an inordinate amount of time discussing these nodules and how to avoid them.
They do, yeah.
Let's break down the pathology here, because there seem to be two very distinct types of lumps forming when this goes wrong.
Right. You have non-inflammatory nodules and inflammatory nodules.
So what is the actual mechanical difference there?
Well, a non-inflammatory nodule is usually an immediate mechanical failure by the clinician.
Like right on the table.
Within days of the procedure, yeah. It's either that superficial placement we just discussed or it's classic overcorrection.
Meaning they just put too much in.
Exactly. The clinician simply pumped too much volume into a space that couldn't accommodate it. The HA molecules clump together into a localized, hyperdense mass.
So the tissue isn't necessarily reacting to it with an immune response.
No, it's just physically constrained.
It's a traffic jam. Like
Yeah.
the material is biocompatible, it's just stuck in a bottleneck because of poor spatial awareness by the injector.
That's a great way to put it. But an inflammatory nodule is a completely different biological event.
Okay.
This is where we see granulomas. And a granuloma represents a chronic, delayed immune response.
Let's dig into that, because the timeline detailed in these journals is wild. A patient might be perfectly fine for 3 months.
Right.
And then suddenly, they develop a firm, rubbery, tender mass. Why the delay? What's happening in the body?
It comes down to how the immune system processes synthetic cross-linking. Hyaluronic acid naturally occurs in the body, which is why it's generally tolerated in the first place.
Yeah. Our bodies already make it.
Exactly. But to make aesthetic fillers last 6 to 12 months, manufacturers chemically bind the HA chains together.
They cross-link them.
Right, they cross-link them so they resist natural enzymatic breakdown. Sometimes the immune system's macrophages, the frontline scavenger cells, detect this heavily cross-linked material or even trace manufacturing impurities, and they flag it as a foreign invader.
But wait, macrophages usually just phagocytize. They engulf and digest the debris? Right.
Yeah.
Why does a hard lump form?
Because the HA gel particle is simply too large and dense for a single macrophage to digest?
Oh, it's too big for them to eat.
Exactly. So when the macrophages realize they can't clear the material, their programming shifts. They actually fuse together to become what are called foreign body giant cells.
Whoa. They merge into giant cells.
Yeah. And these giant cells recruit fibroblasts, which start laying down dense collagen fibers. They are effectively building a permanent fibrotic wall around the filler to quarantine it.
To trap it.
Right. That cellular prison is the granuloma. It is dense, it is highly vascularized, and it feels like a rubbery tumor to the patient.
The body literally entombs the filler.
Yeah.
That is fascinating, but it's not even the most severe risk in our stack of sources.
No, it is not.
We need to talk about the Korean autopsy study. Because this procedure doesn't just risk localized immune prisons, it risks systemic catastrophe.
Yeah, this is where it gets very serious. We are looking at a 2019 forensic report detailing a case of non-thrombotic pulmonary embolism, or NTPE, during a vaginal filler procedure.
Right.
The patient, a woman in her 30s, went into sudden cardiac arrest on the table and could not be resuscitated.
Just incredibly tragic.
It really is. And the autopsy revealed that the thick, undegraded hyaluronic acid gel had completely occluded her bilateral pulmonary arteries.
I want to make sure I understand the mechanics of this, because logically, it sounds almost impossible for a gel injected in the pelvis to end up in the lungs within seconds.
Right, it seems disconnected. but the anterior vaginal wall sits directly adjacent to the paravaginal venous plexus.
Okay.
This is a massive, complex network of low-pressure veins responsible for draining blood from the pelvic organs and returning it to the heart.
So if a clinician isn't paying attention, injecting HA here is literally like pouring rapid-set concrete into a delicate plumbing system.
Exactly.
If it dries on the surface, you get an ugly bump on the floor, which is our nodule. But if you accidentally pierce the pipes and inject that thick gel into the venous return...
The pressure of the syringe easily overcomes the low pressure of the vein.
Wow.
Yeah, the HA gel is forced directly into the bloodstream. It travels rapidly up the inferior vena cava, passes through the right atrium and right ventricle of the heart, and is pumped directly into the pulmonary arterial tree.
So it goes straight from the pelvis, through the heart, and into the lungs.
Yes. The gel physically wedges into the narrowing vessels of the lungs, instantly halting blood flow and oxygen exchange. It is a catastrophic, non-thrombotic embolism.
With a risk that extreme, I honestly just don't understand how any clinician justifies putting a needle in this area.
Yeah.
How is the industry mitigating that? Let's crack open these clinical playbooks.
Let's do it.
What is the step-by-step methodology a responsible practitioner uses to safely navigate this total minefield?
Well, the clinical guidelines emphasize a layered defense system. The absolute cornerstone, the non-negotiable first step to prevent that fatal NTPE, is a technique called aspiration.
Aspiration, right.
Before the clinician depresses the plunger to inject a single drop of filler, they must pull back on the plunger to create a vacuum inside the syringe.
And the playbooks are incredibly specific about the timing here. They insist on a sustained 10-second aspiration.
Yes, 10 full seconds.
But honestly, if you were in a vein, shouldn't pulling a vacuum instantly flash blood into the syringe? Why do they need to hold it for 10 full seconds?
It comes down to fluid dynamics. Remember, cross-linked HA is a highly viscous, cohesive gel.
It's super thick.
It is thick. If the tip of the needle is resting inside a vein and the clinician applies negative pressure, that vacuum has to pull the liquid blood up through a dense column of gel before it becomes visible in the hub of the syringe.
Oh, I see. It takes time for the blood to travel through the gel.
Exactly. A quick 2-second aspiration, which is unfortunately very common in rushed facial aesthetics, will yield a false negative.
The clinician thinks they're safe.
Right. They think they're safe, they inject, and they cause an embolism. The 10-second rule accounts for the viscosity of the filler. If they see blood after 10 seconds, they abort the injection immediately.
Okay, that makes complete mechanical sense. But the playbooks also push heavily for abandoning sharp needles altogether for this procedure.
They do. A sharp hypodermic needle is designed to slice through tissue cleanly, which means it will effortlessly slice right through the wall of a paravaginal vein. To minimize that risk, advanced practitioners utilize blunt-tipped microcannulas, typically 22 or 25 gauge.
So they make a tiny pilot hole, insert the cannula, and the blunt tip sort of pushes the vascular structures out of the way instead of piercing them.
Exactly. It just glides past the veins. It is a much more tissue-respecting approach. It drastically reduces the chance of intravascular injection and minimizes local hematomas.
And hematomas can themselves trigger inflammatory nodules, right?
Yes, blood pooling can absolutely trigger an immune response.
Okay, let's shift back to the hyperdensity issue. Because even if you avoid the veins with a cannula, you still have the problem of this thick gel clumping up and forming a hard lump in the submucosa.
Right, the traffic jam.
Yeah, and I found one technique in the source material absolutely fascinating. Some clinicians are mixing the hyaluronic acid with PRP, platelet-rich plasma, before injecting.
Yes.
Walk me through the cellular mechanics of this. How does mixing blood plasma with filler stop nodules from forming?
It is an ingenious manipulation of viscosity, really. HA filler, straight out of the syringe, is highly cohesive. The cross-linked chains want to stick together.
Like jelly.
Exactly. If you inject that directly, you risk creating a dense focal mass. But by drawing the patient's own blood, centrifuging it to isolate the platelet-rich plasma, and meticulously blending it with the HA in a 1-to-1 ratio, the clinician alters the rheology of the product.
They are essentially thinning the structural integrity of the gel.
They are interspersing the autologous plasma among the synthetic HA chains. It lowers the extrusion force required to push the gel out of the cannula.
It flows easier.
Yeah, and most importantly, it prevents the HA from immediately clumping. The thin mixture can diffuse more naturally through the submucosal planes.
And they pair this thin mixture with a very specific injection pattern, right? They call it the microbolus technique.
Yes. Safe technique here demands extreme patience. A clinician cannot simply deposit a single 2 milliliter bolus of filler into one spot and expect it to look or feel natural.
That would just make a huge lump.
Exactly. So they deploy microboluses, depositing tiny measured droplets of 0.05 to zero point 0.1 milliliters while fanning the cannula in a retrograde motion.
Like painting it in layers.
Right. They build the augmentation drop by drop, dispersing the volume over a wider surface area. Post-injection, they apply a firm, specialized massage to mold the product.
To smooth it all out.
Yeah, ensuring the HA integrates into the tissue as an even, uniform cushion rather than an isolated lump.
It sounds incredibly meticulous. I mean, 10-second aspirations, blunt cannulas, altering the rheology with PRP and drop-by-drop fanning.
It has to be.
But, biology is stubborn, and adverse reactions happen even with flawless technique.
That is always the reality of medicine.
So if a patient comes back 3 weeks later with a hyperdense, non-inflammatory nodule because the filler pooled, what is the escape hatch? Like, how do they fix it?
The primary pharmacological antidote for a hyaluronic acid complication is hyaluronidase.
Hyaluronidase.
Yeah.
Okay.
It is an enzyme that aggressively cleaves the glycosidic bonds of the HA polymer. It rapidly breaks down the thick gel into a low-viscosity, watery fluid that the body's lymphatic system can easily clear away.
But wait a second. We established earlier that the body produces its own natural hyaluronic acid. The tissue matrix is full of it.
It is.
If a clinician injects this enzyme to dissolve a synthetic lump, doesn't it just indiscriminately dissolve the patient's natural tissue along with it? I mean, it's an eraser for HA.
It absolutely dissolves the endogenous natural HA in the immediate vicinity. The enzyme cannot distinguish between synthetic and natural molecules.
Wow. That sounds like you're causing a localized tissue defect just to fix a lump.
Well, it would be, except for the speed of natural cellular turnover. The human body is remarkably efficient at regenerating natural HA. Its half-life in the tissue is only about 24 to 48 hours.
Wait, really? Just a couple of days?
Yeah, so even if the hyaluronidase temporarily degrades the natural tissue matrix, the body synthesizes new HA and repairs the defect almost immediately.
Oh, that's wild.
But the synthetic filler, however, relies on its artificial cross-links to survive. Once the enzyme severs those links, the filler is permanently destroyed.
That is a brilliant physiological loophole.
It really is.
But they aren't just flooding the vaginal wall with this enzyme, right? The playbooks detail a very specific microdosing protocol.
Because the goal is targeted reversal. The patient paid for an augmentation. The clinician doesn't want to wipe out the entire procedure just to fix one localized area of hyperdensity.
Right, you don't want to lose all the results.
Exactly. So they use incredibly low doses, often just 10 to 75 international units. They inject this microdose directly into the focal lump to soften it, leaving the surrounding well-integrated filler completely intact.
Does timing matter? Say a patient ignores a lump and comes in 6 months later. Does the hyaluronidase still work the same way?
Timing is a massive variable here. Fresh filler-like within a few days or weeks of the procedure is easily dissolved. It hasn't fully integrated, and the immune system hasn't walled it off yet. But if a patient waits 6 months and that hard nodule is actually an inflammatory granuloma, the hyaluronidase has to fight through that dense fibrotic collagen capsule.
The prison that the macrophage is built.
Exactly. It has to break through that just to reach the filler inside. It requires much higher doses, multiple sessions, and sometimes concurrent steroid injections just to break down the scar tissue.
Which brings up the most crucial skill for the clinician.
Yeah.
Diagnostics. I mean, they can't just blindly fire an enzyme at every bump they feel.
Correct. Misdiagnosing the nodule can lead to severe consequences. For example, if a clinician assumes a tender lump is just clumped HA, but it is actually a biofilm.
What's a biofilm?
It's a low-grade, chronic bacterial infection introduced during the injection. If it's a biofilm, injecting hyaluronidase is the worst possible move.
Because the enzyme dissolves the tissue barriers, keeping the infection localized.
Precisely. It opens the floodgates, allowing the trapped bacteria to spread rapidly through the tissue planes.
Oh, wow. That sounds terrible.
It is. A biofilm requires a completely different playbook. You need targeted antibiotics, potential surgical drainage, and strict avoidance of any massage, which would mechanically spread the pathogen.
Right. Massaging it would just push the bacteria everywhere.
Exactly. Furthermore, if the original clinician used a biostimulatory filler, like polylactic acid instead of HA, hyaluronidase won't do a thing. The practitioner has to know exactly what material they're dealing with and what biological process is driving the complication.
So, synthesizing everything we've looked at today across these disparate sources, the ACOG warnings, the forensic data, and the clinical manuals, we arrive at a very clear picture of this off-label space.
A very complex picture, yeah.
The G-shot exists in a highly controversial regulatory gray zone. For the practitioners choosing to operate in this space, safety isn't just about having a steady hand. It is entirely dependent on a profound, almost obsessive respect for local neurovascular anatomy and the physics of the materials they are using.
It requires abandoning standard facial injection techniques entirely. It mandates blunt cannulas to preserve venous integrity, exhaustive aspiration protocols to prevent fatal embolisms, rheological adjustments like PRP mixing to avoid hyperdensity, and a masterful grasp of complication diagnostics.
For you listening, whether you are a medical professional tracking the evolution of aesthetic protocols, a prospective patient navigating off-label procedures, or just someone fascinated by human biology, unpacking these mechanics demystifies the buzz.
It really does.
It proves that intimate cosmetic medicine isn't just a simple surface enhancement. It is a profound disruption of deep, dynamic biological systems.
It highlights the sheer resilience of the human immune system and the extreme lengths practitioners must go to in order to safely manipulate it.
It really does. And looking at the sheer complexity of these safety protocols leaves us with a provocative thought to ponder. We've established that the FDA currently warns against the use of these fillers for vaginal rejuvenation.
They do.
But as patient demand continues to surge, and as clinical playbooks become more sophisticated in avoiding these catastrophic risks, how long will this remain an unregulated, off-label frontier?
That is the million-dollar question.
Will the FDA eventually be forced to either aggressively step in and outright ban the cosmetic use of these medical devices in intimate areas, or will they have to concede to the market, standardize the training, and officially regulate it as a new medical subspecialty?
It is a regulatory standoff that will fundamentally shape the future of aesthetic medicine.
A fascinating space to watch. Thanks for taking the deep dive with us. We'll see you next time.